Now I am requesting Dr. Mohsin Ahmed sir for his presentation on anticoagulation in CTO and CHIP PCI. Dr. Mohsin Ahmed sir, please.
Thank you, organizer, especially Professor Abdul Qadir sir, also Amrujjaman Khan W sir, and also our respected chairperson, panelists, and participants. Assalamu alaikum, good afternoon. My topic is anticoagulation in CTO and CHIP PCI. Already Professor Saidi Rahman talked about the CHIP PCI. The most important but theoretical part of the anticoagulation, you should know about the anticoagulation in the CHIP PCI. Topic we discussed: anticoagulation classification, anticoagulation and CHIP PCI, anticoagulation CTO PCI. You know, everybody, anticoagulation is the both routes, parenteral and oral route. Parenteral is the indirect and direct. Indirect, you know, unfractionated heparin, low molecular heparin, fondaparindex, and direct is thrombin inhibitors and factor Xa inhibitors. And oral is indirect. Direct is vitamin K antagonist, and direct is thrombin inhibitors, dabigatran, and factor Xa, rivaroxaban, epixaban, and endoxaban. These are all the novel anticoagulants, you know. And there is different classifications. Is the vitamin K anticoagulants, you know, warfarin and heparin, heparinoids, and direct thrombin inhibitors is the bivalirudin and any other. And there are some direct factor Xa inhibitor, epixaban, bectixaban, endoxaban, otaxaban, and rivaroxaban. So we always use the anticoagulant in the cath lab procedure. You do the PCI, also do the mechanical support, transcatheter therapeutics and ablation. We use the anticoagulants. Why? You know all the thrombogenic potentials, and there is some principles to manage the bleeding and thrombosis in the cath labs. You should know the thrombosis and so who is anticoagulants used in the cath labs? You choose the anticoagulants with short duration and easy to monitor and potentially reversible. That is balance between the bleeding risk and thrombogenesis. Previously, Professor Saidi Rahman stated CHIP PCI is the patient comorbidity and complexity and hemodynamics. So we should not only the complexity. You should not forget about the patient comorbidity, that is ACE, CKD, stroke, and also know the patient hemodynamics, that is LV dysfunction. So anticoagulation, you know everybody, there may be plaque rupture in the PCI, so plaque aggregations, and there may be thrombosis. So we, in the previous date, you use the oral anticoagulants, but some novel antiplatelets, the dual antiplatelets, we should not use the anticoagulants in routinely. You know there is long listing use of anticoagulants in the cath labs, in the unfractionated heparin, low molecular heparin, bivalirudin, and agratroban and fondaparindex we discuss in later on. So in the optimal intensity and how much you use the anticoagulant PCI. And unfractionated heparin has been used traditionally 60 to 100 units per kg, but in case of CHIP PCI, you mind it, you concomitant use of glycoprotein 2B3A receptor. So always kept in mind in advanced age, CKD and other comorbidities, there may be thrombosis and bleeding. So you should you should know about the anticoagulants. And in most of the cases, we can stop the anticoagulants, no need of anticoagulants after the procedures. Most of the cases, because there is a chance of bleeding. You kept in mind in your cath labs. Always in the cath labs, you should be concerned about the ACT value. And on all the trials in OASIS 8 and Futura trial and STIP trial shows that ACT is 300 to 350 milliseconds is the sufficient to maintain the lowest ischemic bleeding and complication rates. So enoxaparin is the most important, most commonly used drug in the cath labs and can use in the IV form. In STIP trial, you show there is IV enoxaparin. IV enoxaparin is 0.5 milligram per kg body weight, and IV enoxaparin 0.7 milligram per kg body weight. And also there is IV heparin. There is a three arm. They showed that there is less bleeding in the IV enoxaparin. And also there is 30 days data, neither modality and MI and transpecular is different between three groups. So you can use the enoxaparin IV in the cath lab in the CHIP procedures. and fondaparinux. Fondaparinux is the sometimes used, but in Oasis trial is showed the fondaparinux is less bleeding, but Thyroiditis mortality is less. But mind it, it causes the increased catheter thrombosis. So should not use solely. Should use the unfettered heparin in a renal procedure. In bivalirudin, bivalirudin is the most very nice anticoagulant. It's directly acting synthetic antithrombin. It not activate the platelets, does not bind the plasma protein. So directly acting, it not produce the heparin in the thrombocythemia. It is less excretion in the kidney. So this may be important in the CKD patients. So in the cheap case, CKD patient in case of use very short acting. So you can use easily. Dose is the 0.75 mg per kg body weight and prior intervention, and followed by 1.7 mg per kg hour. And ESC recommended in CKD cases is reduce if less than 30 ml per minute, reduce the dose 1 mg per kg per hour. But there are some trials, equity trial and horizontal trial shows that is less bleeding and there is less bleeding and is mortality is less. So in this trial, it show there is heparin plus bivalirudin. All the trials shows bivalirudin is monotherapy is actually the less bleeding, but in some cases they showed early stent thrombosis in case of bivalirudin. But bivalirudin is used in all cases. In CKD patient, you saw CKD patient, unfractionated heparin is preferred because it is short half-life, even in patient with severe renal dysfunction, the minimum hemorrhagic risk. So you can use the unfractionated heparin safely in CKD patient. But also there may be antidote is present in our cath labs. Low molecular heparin, you can use the enoxaparin. Also use the bivalirudin also. And direct thrombin inhibitors, acrabotin and bivalirudin can be used in your cath labs. So there here show unfractionated heparin, you can reduce dose if creatinine clearance less than 15. Enoxaparin, you can use 1 mg per kg body weight in single dose, and dalteparin, and also acrabotin, that is bivalirudin using if renal clearance less than 15. Chronic anticoagulation after some you saw in cheap cases we deal with the advanced ages. So there are a lot of patients with the atrial fibrillations. So we use the chronic anticoagulation after PCI. It is only atrial fibrillation, 5 to 10% of PCI patients, artificial heart valves, previous venous thromboembolism, and intracardiac thrombi. You can use the oral anticoagulants, but not recommended in the all cases. All cases you use the only dual antiplatelet therapy. There is a lot of trials shows the West trial, Pioneer trial, Readwell, PCI trial, and August trial, and test they show multiple that shows double therapy with NOAC has lower risk of bleeding compared to the triple therapy. Sometimes we need the triple therapy because there is thrombus, but it causes the bleeding. There it shows you use the dual anticoagulation therapy because in case of triple therapy, in cheap cases, especially advanced age and chronic fluid causes the bleeding. There is in some cases we use the oral anticoagulants without atrial fibrillations. In some cases, where there are thrombus and CKD patients, in case they use the twice daily dose of rivaroxaban 2.5 mg BID, they showed the reduction of the stent thrombosis and mortality in their trials showed the benefit in giving the rivaroxaban 2.5 mg BID in patients without atrial fibrillations. So we should always concern about the risk of bleeding in patients undergoing PCI. We should concern about the risk of bleeding because there is bleeding chances more in case of CKD patient, advanced age, any other stroke patients, hemorrhagic stroke. So we should concern about the major and minor criteria should find out the cases. So what do we do? Anticoagulant doses adjusted to body weight and lung function, especially in women and elderly patients. You should adjust your dose. You should make real approach. Proton pump inhibitor you can use, and PCI. If patient is on NOAC, if patient is getting the oral anticoagulants, PCI can be performed without interruption of the vitamin K anticoagulants or NOAC. In patient with vitamin K anticoagulants, do not administer unfractionated heparins. So you keep in mind always. So when you choose the antithrombotic treatments, which concern about the patient age, sex, and also previous history of ischemic episodes, bleeding episodes, and also patient clinical condition, that is chronic testicular angina and acute coronary syndrome, patient having the CKD, diabetic. So we should always finding out the comorbidity of the patients before getting the anticoagulants. So if the patient is advanced ages and renal function, you can easily use the renal dysfunction. CKD, you use the bivalirudin and unfractionated heparin. If there is bleeding risk, you use the bivalirudin and fondaparinux. If ischemic risk, you use the enoxaparin and fondaparinux. So if it's the early onset of the early cases, you short-acting bivalirudin and unfractionated heparins. CTO PCI, you know, CTO PCI, GPCI, why around the 20% of CAG, CTO PCI less than of PCI, CTO PCI is a less success rate and more complication. It's like the same days bleeding already. So
recording in progress.
Always keep in mind ACT value is 300 to 350 seconds ischemic bleeding. ACT should be checked every 20 to 30 minutes. Take a message, cheap patients are being under-treated. These large group of patients are benefited from revascularizations. Rather than focusing on the low-risk group, who may be easy to treat, we should go for the cheap procedures. In order to optimize the safety of anticoagulation use, operators, cath lab staff need to be aware of nonsense of various testing device and therapeutic goal, and we should follow we should build a cheap program in our cath labs. So by the doing of the cheap program in our cath labs, we can save our patients in the bleeding and also thrombosis. Thank you, everybody. Thank you for patient hearings.